Good evening, good afternoon, and good morning to all of you, and welcome wherever you are in the world. My name is Dr. Shraddha Kotwal, and I'm very excited to host this episode of the Tea with Africa series, focusing on kidney disease, particularly given that today is World Kidney Day. I'm a kidney specialist. I'm based in Sydney, Australia, and the program head of the Renal and Metabolic Division at the George Institute for Global Health, based in Sydney, Australia. My research expertise is in the use of big data sets to answer important questions, in conducting clinical trials using pragmatic and novel clinical designs. And I believe that all people everywhere in the world should have access to good quality healthcare. Let me introduce the George Institute a little bit. The George Institute is an independent global medical research institute with major centres in Australia, China, India, and the UK, and an international network of experts and collaborators. Our mission is to improve the health of millions of people worldwide, particularly those living in disadvantaged circumstances, by challenging the status quo and using innovative approach to prevent and treat non-communicable diseases and injury. With regards to the kidney space and the specific work we're doing here, before I say that, I will talk a little bit about chronic kidney disease, just to set the scene a little bit. There are 5 stages of chronic kidney disease, with the final stage called end-stage kidney disease. Once people reach end-stage kidney disease, they need kidney replacement therapy, or they die. Chronic kidney disease is a global problem, and we'll hear a lot more about that as we go on today. But up to 1 in every 10 people have some type or stage or marker of chronic kidney disease, which is a huge number of people worldwide. Moving on to talk a little bit about the research we do. From a research perspective, at the George Institute, we're leading several trials that aim to prevent the progression of kidney disease, some that prevent the complications of kidney disease. We have expertise in cohort studies that look at measuring the number of people with kidney disease and their outcomes, and including the impact on their day-to-day lives, which is huge, as you'll hear about as we go on today. We have collaborations with several countries around the world, including India, China, Fiji, and with one of our speakers today in Zimbabwe. Our work aims to improve outcomes for people with kidney disease, and we've partnered with patients and clinicians and researchers across the world to work towards our aim. I say work towards because
My network is so poor, eh?
Even though we've made substantial improvements, there's still a lot of work to be done and lots more work we can do to improve outcomes
but the network
for
is
people
not good at
in
all.
this world.
Sorry, can everybody hear me?
Yes, we can hear you really well, Mr. Sibanda. So a little bit more about what we're doing. We have actually, I've talked about this. One of the things I will say is we like thinking outside the box and we like solving hard problems. Of the work we've done over the years, I would really like to highlight one specific one. This study was very important in highlighting to the world that there are large gaps in access to kidney replacement therapies. It's estimated that by 2030, more than 5 million people around the world will need kidney replacement therapies, but only half will be able to access them. And these numbers were particularly stark from this study for Africa, which show that sadly, between 84 to 90% of people who would need kidney replacement therapies in Africa will be unable to access it. Which I think is a nice entry point into talking about the George Institute's Africa Initiative. Through our Africa Initiative, we're hoping to establish authentic and long-lasting connections with institutions and academics that work in Africa. In the chat section today, please let us know if you would like to partner with us. What we're trying to achieve with this Tea in Africa series is firstly that Africa is a continent of about 54 countries, and we do not wish to ignore the diversity on the continent. On the other hand, we wish to acknowledge it and celebrate it. We've termed this series Tea with Africa because we want people to think of a relaxed atmosphere in which to engage with these diverse voices and scholarship from Africa. This is the first of the series for 2023. And I hope that you will engage with today's session. Please add any comments or questions into the chat feature or the Q&A section, and we will be monitoring it throughout the event. So the aim of today's session is to raise awareness about chronic kidney disease in Africa, challenges, need for opportunities, and gauging interest around collaborative research and looking at potential approaches that could reduce the instances of kidney failure. So while we will be hearing from our panelists, we're very interested in also hearing from all of you who are on listening to us today. So again, please share your experiences in the chat section and questions in the Q&A section. Let me now introduce our panelists. So our first panelist is Dr. Rumbi Dawa, who graduated with an honours degree in Bachelor of Medicine and Bachelor of Surgery from the University of Zimbabwe in 2003. She pursued postgraduate studies in Australia and qualified as a specialist physician and nephrologist in December 2013. Dr. Dawa is head of the renal department at the Sally Mugabe Central Hospital and does consultant renal work at Pari Hospital. She's currently a lecturer in the Internal Medicine Unit at the University of Zimbabwe, Faculty of Medicine and Health Sciences. The University of Zimbabwe is a public university in Harare, Zimbabwe. And because she didn't have enough to do, she's also pursuing her PhD under Professor Martin Gallagher at the George Institute. Our next panelist is Mr. Lysias Sibanda, who is a member of the Institute of Chartered Accountants of Zimbabwe, with a wide range of experience in the financial sector. He has kidney failure and is passionate about causing a shift in the level of service to kidney patients in Zimbabwe through the Kidney Association of Zimbabwe and the organisation he leads, B. Braun Zimbabwe Limited, spreading dialysis services throughout the whole country. Our next panelist is Dr. Cindy George, who is a senior scientist at the South African Medical Research Council and holds a PhD from the University of Stellenbosch, South Africa. Cindy's research area is centred around chronic kidney disease in African populations, focusing on characterising the burden of CKD and examining the risk factors and underlying mechanisms associated with the disease. She was key in establishing and currently manages the CKD Africa Collaboration, which is an African network of studies with renal outcomes. The aim of the network is to pool individual participant data and understand the burden of chronic kidney disease in Africa, as well as to create resources that will allow this burden to be tracked and enable CKD projections to be made in the context of Africa. To date, the network has access to more than 60,000 individual patient data from 15 countries, and more studies are in the process of enrolment. She's a South African National Research Foundation rated scientist and an Africa Oxford Fellow. So welcome, Mr. Sibanda, Dr. Dawa and Dr. George. It's our great pleasure to have you here today. Let's go into our first round of questions. So, Mr. Sibanda, perhaps I could invite you to share with us what is life like for a patient with CKD in Zimbabwe, and tell us about your experiences and challenges.
Thank you very much indeed. I thought I'll be brief. For me, in particular, what I've experienced is more from a psychological, lack of intervention, so to speak. I found kidney failure to be a source of great anxiety and fear. For me, in particular, I didn't know exactly how my life was going to change. No one was going to told me or taught me. There was no education to say, okay, fine, listen, you know what? Your body is going to change this way. This is how things are going to be. Your diet is going to change this way. I think it was simply go on hemodialysis. That's it. And I think it's just not good enough. And I've discovered as I've gone through with the treatment. Of course, I've had over 19 years on CKD now and on hemodialysis. But I've had to deal with things as they come without any particular intervention from, the health authorities to say, okay, there's a psychologist or a social worker going to help you and know exactly how things are going to be and how difficult things are going to be. Because there's a lot of stuff that changes, especially in the family. A lot of strain in the relationship with your family because things are no longer going to be the same ever. And I think the solution becomes, just intervention in the form of, kidney transplant. Because other than that, honestly, life of a kidney patient is very, very difficult. Especially when you catch other things like COVID and so on. It's very, very tough because you become very susceptible to those diseases. They hit you worse than a person who isn't actually, who is not on sick leave. So I thought I would just limit it to psychological intervention. There are a lot of other things, obviously, which I can talk about, but in the interest of time, I thought I would limit myself to that.
Thank you, Mr. Sabanda. I think what you describe, particularly around the family strain and the psychological burden of kidney disease, is something a lot of my patients have shared with me as well. I might move on. I might come back to you in a bit and move on to asking Dr. Dava to tell us a bit more about what is kidney disease, and from her perspective, what the challenges and needs are to dealing as a kidney specialist in Zimbabwe.
Thank you so much, Shraddha. So I think you highlighted quite well in terms of the definitions of chronic kidney disease, so I won't talk about that. But I think it's important to highlight why chronic kidney disease is so important. And one of the things we know is that there's, quite a high prevalence of chronic kidney disease. So if we look at some of the studies that have been done in sub-Saharan Africa, it's estimated that the prevalence of kidney disease is about 13%. And if we look at a country like Zimbabwe, that translates to about 2 million people who are at risk of developing chronic kidney disease. So it's certainly an important thing for us to be talking about. And particularly, like you highlighted, once people get end-stage kidney disease, it is quite expensive to treat. And in some of the research that we've managed to do, we actually found that in Zimbabwe, the patients who've got end-stage kidney disease and are on dialysis are quite young. So the average age is 53 years of age. And if we compare that with other developed countries, we can see that this is a very young dialysis population. And these are people who should be in the community with their families, being productive, and yet they're spending a majority of their time on dialysis. So I think thinking of some of the challenges, certainly one of the major things is policies. So there's a lack of data to actually drive policy formulation in terms of chronic kidney disease management, renal replacement therapy. And at the moment, we actually don't have a dialysis policy in the nation to guide clinicians about who gets renal replacement therapy. And more so in a country where most people are actually not being managed by a nephrologist, they are being managed by general physicians. So it's really at the discretion of the treating physician in terms of who gets to access renal replacement therapy. And if we look at clinical challenges, although the government has come up with a policy to say renal replacement therapy is free, so that started in July 2018, but it's only the dialysis that is free, and patients still have to pay out of pocket for lab tests, for any medications, and that's only within the public sector. And even then, the resources are not enough to cover for the number of patients that we have to treat. And I think the other issues Mr. Sibanda has already highlighted. If we look at staffing, we currently have 5 adult nephrologists and 1 pediatric nephrologist in the country. And Zimbabwe has an estimated population of 15 million people. So I'm sure if you look at those numbers, you can see that there's a huge need. And we only have 1 facility that actually trains renal nurses for the whole country, and they only have 1 intake per year. So again, we can see that there's a lot of deficit in terms of the staffing. And I think Mr. Sibanda highlighted quite strongly that we don't have the other allied health staff, the psychologists, the social workers. So it's not just about patients coming into a unit and maybe getting dialysis, but there's a lot of teamwork that needs to occur in terms of managing our patients. So I think that really summarizes some of the challenges that we've had in terms of managing patients who've got chronic kidney disease, and particularly those with end-stage kidney disease.
Thanks, Dr. Dawa. Those are some very stark numbers and quite scary what you're describing. I might now invite Dr. George to talk about the CKD Africa collaborative experience around research, and if you can share with us what we can do to prevent the need for dialysis and to offer quality treatments in this area.
Thank you so much, Dr. Cowell. Good morning from South Africa to all listening. I firstly just want to thank the George Institute and the Tea for Africa initiative for inviting me to sort of contribute to this very important topic of CKD in Africa. If we listen to the lived experiences just presented by Mr. Sibanda, as well as the clinician's perspective presented by Dr. Dawa, it just again highlights this need for increased awareness of CKD and the need for increased research into the drivers of the disease in Africa. So Dr. Caldwell mentioned earlier that the global prevalence of CKD is around 10%, but in Africa, the prevalence is estimated to be closer to 13 to 16%. So, however, due to this lack of data in many African countries and the limitations in available data, the true burden of CKD in Africa is probably underestimated. So in short, I will be telling you a bit later on about the actual consortium and how we are trying to collaboratively try to address this problem. I just quickly wanted to focus on this disproportionate risk of CKD in Africa that is sort of mainly driven by the high and rising prevalence of hypertension and type 2 diabetes. So these are the 2 major risk factors for CKD. And now to add to this risk, we also have this high burden of infectious diseases and a genetic predisposition to CKD. So as Dr. Dawa just mentioned, as Africans, we are actually affected at a much younger age, and we have a more rapid progression to kidney failure compared to other populations. Now, given the study that Dr. Cotwell also mentioned earlier, that between about 85 to 90% of people in need of kidney replacement therapy in Africa are actually not able to get it, there's a large proportion of people that are suffering prematurely. So awareness of CKD is very important. However, we have found that awareness of CKD remains very limited in Africa, and a large proportion of people with CKD, and these are usually the people sort of in the early stages of CKD, go undetected, and generally people are only diagnosed sort of when the renal replacement therapy is required. So this is where the need for early detection of CKD comes in. And this would obviously then reduce the progression and reduce the related morbidity and mortality associated with the disease. So this is where the importance of screening comes in. And although research shows that it is not necessarily cost effective to screen the general population, screening those at high risk for CKD should actually become a priority. So when I speak about the high risk groups, I'm here referring to people with diabetes and hypertension, but also people with pre-diabetes and elevated blood pressure. As we've shown in a research study that 1 in 5 people at risk of diabetes, so these are people not yet classified as being diabetic, have CKD. And we found that the majority of these individuals were in the early stages, so stage 1 and stage 2. So through screening people at risk of developing CKD, one can then identify and then manage the disease early, and in this regard, delay the progression to end-stage kidney disease and thus the need for dialysis. But with all this said, obviously, it's not as straightforward as that. As Dr. Dower just mentioned, there are numerous complications, numerous issues that also needs to be dealt with in this regard. Thank you.
Thanks, Dr. George. We might move on to, I might come back to the questions from the audience a little bit later. And what I might do is ask you all to share with us. So perhaps Mr. Sibanda, you could share with us how you responded to some of the challenges that you mentioned earlier around family strain and the psychological distress of needing to be on dialysis. It's a difficult one.
Well, life goes on. I suppose that's the old adage of life, but it's not been easy. For instance, if you are on peritoneal dialysis, your wife has to be involved in terms of, connecting you to the machine and taking you off the machine. One then has to say, is it something that my wife should be doing, or should I be getting a nurse to do it? So there are all sorts of things. You really feel that you are really burdening your spouse with something that she shouldn't be getting involved in. So there's a feeling of guilt to say, okay, fine. I mean, even when you don't feel that well, sometimes the level of lethargy that happens when your ratios are bad, like when your HB is low and so on. People cannot understand the level of lethargy, the incapacity to do anything at home, to assist. So it's something that really you feel is a burden on the relationship with the family. But one wonders exactly how we can do this. I think maybe some social, psychological intervention to teach the spouses to understand that, look, this is how you have to live with the person with that condition. I think that would be of assistance, but that is never available at all. It's not available. Yeah. And there are times when obviously you can get into situations where you get very sick and you're admitted into hospital. I tell you, it's a bad time for family, because really they are not very hopeful in terms of you continuing to be alive. So it's something that's very difficult for everyone. So CKD is not a joke. It's something that really needs permanent intervention in the form of, I think, like I said before, in my opinion, transplant is the best way to go. Without transplant, I think, and for Zimbabwe, Dr. Dawa will tell you that there's no one with capacity to do transplant in Zimbabwe. If you try to think of doing it, you have to go overseas, and it's very, very expensive. First of all, you have to identify a donor yourself, because that's the only way, I think, in my opinion, you can have a reasonable standard of life and stop your family from suffering.
Thank you. I think it's very eye-opening what you're describing, and doesn't sound, so I might move on to inviting Dr. George to talk about how we could, or how you have responded to some of the challenges you mentioned, and how we can, how people within and outside Africa can help address these challenges.
Yeah, it's actually very disheartening listening to Mr. Sibanda and again, like awareness. And it's very important. And also looking at, as I mentioned, the risk factors for CKD. So even before you get to the point of dialysis, there are things we can do. We can raise awareness of, for example, people that have hypertension, that have diabetes, or are at risk of these diseases. Are on medication, are they taking their medication, are they hypertension, are their blood pressure and their glucose levels managed? You can do all of these things to sort of try and reduce the progression of this disease and the devastating effects that it has, because in actual fact, if an individual reaches end-stage renal disease, it's very difficult, as Mr. Sibanda mentioned, to get a transplant, and even the whole setup of going for dialysis, it's taxing on all individuals. Now, as I mentioned earlier, in Africa, the data on the true burden of CKD is very limited, because there's a lot of countries in Africa where we don't really have data. So there's not a lot of research done there. So we don't really know what the prevalence of CKD is in certain areas or certain countries in Africa. And what we at the South African Medical Research Council, so we saw the gap, and we established the CKD Africa collaboration. I just very quickly want to share my screen and just quickly show you something. Sorry, just give me a quick second. Are you able to see my screen?
Yes, we can see your screen.
Okay, perfect. So, as I mentioned, we established the CKD Africa collaboration, which is an African network of studies with renal outcomes. So our aim is to pool data at individual participant level from existing African studies to enable the burden of CKD to be determined more accurately. And we also aim to create resources for the burden of CKD to be tracked in future, and for the projections of CKD to be made in the context of Africa, so that we can see where we are. With this, we aim to provide reliable estimates to determine or to develop policy solutions to address the consequences of CKD in Africa, and also to inform health service planning. So in addition to obviously the scientific outcomes, we also aim to link CKD investigators by providing this platform where we can sort of in a collaborative way plan future studies in a more coordinated fashion. This platform also seeks to create a forum where we as researchers can collaborate and potentially offer advice or guidance concerning topics related to things like study design, implementation, and the like. So this network is in a unique position to provide evidence that could inform health service policies and guidelines in Africa, as well as expanding the idea of research in CKD in Africa. So on the slide, I just want to show you where we currently are. So CKD Africa collaboration, we do have a website. So if you want to go and visit that website, you'll be able to see where we are, what we've done, our current partners. So to date, as mentioned earlier, we have access to just over 60,000 individual participant data, and this comes from 15 different countries. We also have, it's actually now close to 60 investigators that are part of this collaboration. But obviously, we always seek to establish additional unique and long-standing connections with institutions and researchers conducting research in the field of CKD. So if you are interested as a researcher or as an institution to collaborate with us, by all means, please get in contact with me. I think my email address will probably be in the chats, or you can reach me via our consortium. Thank you.
Thanks, Dr. George. Perhaps I could now invite Dr. Tawa to tell us about how you think we could how you have responded to some of these challenges and what we can do to help.
Thanks, Radha. So I think one of the things that I found that has really helped is my affiliation with the university. So in terms of teaching, particularly undergraduate and postgraduate teaching, which means that the younger crop of doctors are more aware of chronic kidney disease and hopefully are screening for it as they see those high-risk patients that Dr. George has already highlighted. And in terms of the postgraduate students, what has also happened is that it has raised interest in doing dissertations around various issues in chronic kidney disease, which has been good for us. And we've actually had a few publications that have come through from our postgraduate students. So that has been quite encouraging. And since I returned to Zimbabwe about 7 years ago now, we've actually managed to have 2 adult nephrologists and 1 pediatric nephrologist trained within that time. So I'd like to think that because we are in our own small way talking more about chronic kidney disease, talking to the trainees that we are interacting with about chronic kidney disease, it has also resulted in an interest in the specialty. So those are certainly things that I'm, quite pleased about, although we still have quite, significant challenges. We have tried to have programs running in terms of World Kidney Day annually, although there's been a bit of a lag in the last few years because of the COVID pandemic. But certainly that's one thing that we've tried to do, and liaising with the Ministry of Health through their non-communicable diseases department. But there's still a huge amount of work. And I think Dr. George highlighted the issue about, further research data, and particularly in Zimbabwe, we need our own local data that will help to guide some of those policies that we need to put into place. And even access to basic screening tests, urinalysis, for example. I've worked in certain institutions where you can't get a urinalysis. And so these are, things that seem so simple, but are quite difficult and challenging to get at some point. And I think Dr. George already highlighted our high-risk populations. We're not managing the high-risk patients well in terms of follow-up of patients who are diabetic or who have hypertension. And we also have the added burden of HIV in our communities. And we know that some of the treatments that we use for HIV can have, quite deleterious effect on the kidneys. So, for example, we still use TDF, the form of tenofovir, which we know is linked with kidney disease. So there are certain things that we really need to do better in terms of managing our high-risk populations.
Thanks, Dr. Dawa. We have a series of questions on the Q&A. But perhaps because I'm host, I might ask one question myself. One of the key messages, I guess, that's coming across to me really is around the lack of policies or lack of services. And do you all have thoughts on, who should drive this policy change and how you think this policy change, that could be around dialysis provision, access to preventative care, more research, just sort of across the board, really. So perhaps I can invite Mr. Sibanda to comment.
Yeah, in my opinion, obviously, I think the CKD is such a big problem. One can see it even as not an expert, not necessarily a doctor or physician. It's so big, this problem. And it can only work provided you have intervention at government level. In other words, the Minister of Health really has to have capacity and the desire to solve the problems that are involved. I think to a certain extent, the Minister of Health could also work with, organizations that are just below it, which it delegates to work on policy and so forth, to create a very effective system that manages that kind of situation. We in Zimbabwe are seeing a total absence of public policy. In other words, government intervention. There's a crisis in the health sector as far as to talk about CKD is one thing. I mean, there's a problem with cancer treatment, all the other things that you are talking about, diabetes management, and you know, all the other non-communicable diseases. So really, at the end of the day, you know, we think that things have to work in the public sector as it is concerned. If it doesn't work there, I can't see doctors voluntarily putting their own resources and trying to turn that situation around. It's totally impossible to have that done.
Thank you. Look, I agree. I think it needs to be a wider government level policy decision. Dr. George, would you like to comment?
No, I just briefly want to add to what Mr. Sibanda is saying. But the thing is I think we all have a hand in this. So as the patient, as the physician, as the scientist, as the government, we all need to partner. And I think we should partner from the get-go to try and get to the bottom of this. Because it is, if you look at only the government's input, there are other diseases, like Mr. Sibanda just mentioned. There are other issues, housing, you know, a lot of other things that the government also needs to sort of address. So it's difficult to just then focus on kidney disease and say, you know, the government needs to sort that out. I agree, it should be at a level of government to change policy in order for things like dialysis, who gets dialysis, who doesn't get dialysis, who pays for it, needs to be addressed. So I do agree it needs to come from that level. And I do think that we all need to sort of hold hands and try and sort this out.
And work together. Dr. Tava, perhaps I could invite you to comment, and then I might go to the Q&A in the chat.
Thanks, Shraddha. So I agree with Mr. Sibanda that we certainly need a lot more commitment from the government, particularly the NCD's department, in terms of policies. But at the same time, again, to have an impact in terms of shifting the current setup, we need the information. So, for example, when in 2018, dialysis was made free in the public sector, they didn't then factor in some of the other things that come with dialysis. So we now had patients who had no financial resources to then pay for the blood tests that are required for dialysis. So they would come to the unit, get dialysis, and then at the end of the month, we say, well, we need some blood tests. And they can't pay for those blood tests, or we need to put you on certain medications, which they can't afford. So it needs to really be a holistic approach to the management. So we can't just say the renal replacement therapy is free without actually also giving some of the support services that are required. And then also looking at policies around management of patients who've got hypertension, who've got diabetes, but certainly, yes, even within the communities, I think one case is diabetes. So the Diabetes Association has been very vocal in terms of explaining to government some of the challenges that they are facing as diabetic patients. And at some point, they even managed to lobby for insulin and other medications to come in at a subsidized rate. So I think there is a role also for the patients themselves to have a voice and to speak clearly about these challenges, and to lobby government about certain things that pertain to them directly. Because you can see from Mr. Sibanda's experiences that from a patient's perspective is very different from what I think as a clinician. So it needs to have, you know, all the different voices speaking and lobbying government to implement some of these changes that are required.
I couldn't agree more. I think that the patient voice is much more powerful than I think our patients realise. So I might go to the Q&A now, and the first question is if there is any data on funding for CKD prevention and treatment in Africa. Do you mean data available on what funding sources are available, or I'm just trying to understand the question. But maybe Angus, you could clarify that in the chat, and I might go to the next question. So there's a comment from Daniel who says, thank you to everyone who participated in this initiative. It's important to discuss the data limitations for NCDs in general, and particular for CKD in Africa. And I think that's what Dr. George, you were talking about earlier, how we need the data to tell us how bad things are, which then allows us to lobby for change. I have a question here from Patiti, who wants to know if you could comment about gestational diabetes and CKD, and perhaps that's best directed to Dr. Tawa.
So is this in terms of screening?
Yes, I think, because the follow-up question is, given the predisposition, isn't it prudent to start from the prevention from pregnancy for CKD and gestational diabetes, presumably?
So certainly there is screening that is done during pregnancy, but I think Dr. George highlighted some of the challenges that we have. We have patients who present unbooked and in labor, so they've not even had any antenatal care. And we have, challenges, even like I said, sometimes getting the urinalysis strips in some of our public institutions. So the knowledge certainly exists, but not necessarily sometimes the resources that are required to undertake some of these management or screening procedures.
Or can I just perhaps add on that? So I think with gestational diabetes, it just puts you at risk of developing full-blown diabetes later on, and that risk is then the risk of you getting CKD. So I would, for somebody that has had gestational diabetes, obviously your risk is higher now for type 2 diabetes. So I would think that you are a candidate to be screened sort of on a regular basis.
Thank you. So Angus has clarified his question, which is what the health expenditure in Zimbabwe is regarding prevention of CKD as opposed to hemodialysis treatment. And if you've got a sense for that.
So I think I don't personally have the data, and maybe that would be something that if we had someone from the Ministry of Health, they'll be able to give us. But certainly I haven't seen any publications that talk about health expenditure in that particular regard.
Thank you. The next question is from Professor Mark Woodward, who's asking about sex differences in CKD care in Zimbabwe, and if you could comment on that.
So thank you, Prof. Woodward, and thank you for greeting me in my local language. So in the study that we did looking at dialysis prevalence, it was interesting that in patients who are on hemodialysis, 70% were male and 30% were female. But when we looked at peritoneal dialysis, it was the other way around. There were 60% females and 40% who are males on peritoneal dialysis. So yes, certainly there are sex differences in terms of care in patients who are on end-stage kidney disease. And we are trying now to look at the data for chronic kidney disease.
That's very interesting. Thank you. If I can comment, the data in Australia is, I think, 60% male receiving kidney replacement therapy or dialysis, and 40% female. So those. Then I have a comment from Leilani Johnston, who says we need a drive in patient advocacy. Many patients are going to need renal replacement, but the kidneys needed are not donated often for cultural reasons, especially in South Africa. We need to change perception. So I think this is talking more about the transplantation piece. And I think that's all. Have I answered? I think we've been through all of the questions. I'm just keeping an eye. Yes. No, I think that's about all. I've addressed most of the questions in the chat. Perhaps I could invite you all to just make, if you've got any other comments before, anything else you'd like to highlight? Oh, there's one more question which I missed. My apologies. Does Zimbabwe have policies to tackle the risk factors Dr. George mentioned? High blood pressure and type 2 diabetes, action on use, availability of salt, sugar, and junk foods that lead to obesity?
So unfortunately, currently we don't have policies that speak to management of those issues. So again, it is one of the areas that we certainly need to work on.
Thank you. And that was a question by Leonard Veerman. And the other point that Leonard Veerman has made is that Mr. Sibanda made the excellent remark that treating all patients with kidney disease will require enormous resources. So in addition to gearing up the health system, prevention is key. And I think, Dr. George, you touched on that as well when you spoke about controlling blood pressure, making sure sugars are well controlled, and limiting obesity. So I think that's the end of all the questions I've been told. I haven't missed any now. So I might move to the closing remarks. So perhaps, Dr. George, I can ask you to just wrap up, or just some last comments.
Thank you. And I just want to reiterate the awareness of kidney disease and the awareness of the risk factors that are associated with these, to keep these balanced, to keep it regulated. If you're on medication, take your medication, keep your blood pressure and your glucose levels in order. And then also we need to advocate for screening of individuals with CKD, or that are at risk of CKD. So awareness and screening is my final comments. Thank you.
Sorry, I was muted. Thank you for that. Perhaps, Mr. Sibanda, I could invite you to give us some closing remarks. I'm sorry, you're muted. We can't hear you.
I was going to say that where we need intervention is availability of drugs, that are used in the treatment of CKD. You do your monthly bloods, and then you then have to look for supplementary, drugs like, what do you call the drug that you use for HB and so forth, to counter HB and so forth. And tend to struggle to get those drugs. And when we get them, they tend to be too expensive. So I don't know, maybe we need to look at patients and see how we can facilitate maybe wholesaling of those drugs so that we keep the price of drugs down. It's something that is out of our control at this point, because if you want a good standard of life, you also need the medication to maintain a good standard of life. And that tends to be unavailable or very expensive. That tends to be our experience.
Thank you, Mr. Sibanda. I think those drugs are very expensive now. And generally, no matter where you are, unless there's government-funded programs, they are often, or insurance companies or whatever, they're generally unaffordable for any, for people to access without some government level funding. Sorry, Dr. Dawa, perhaps I could invite you for some closing remarks.
Thank you. So I think my remarks are very similar to Dr. George, given that we live in quite similar environments. So awareness, awareness, awareness. I don't think we can say that enough. There's been historically, a lot of focus on infectious diseases. And so the non-communicable diseases have really lagged behind in terms of just getting the limelight. And even in non-communicable diseases, most people then would know about hypertension, diabetes, but chronic kidney disease, again, has not received, I think, the importance that it deserves. So I don't think we could highlight the importance of awareness enough. And we certainly need to do a lot more work in that space. And again, screening, management of our patients, and the research that we still need to do in terms of getting that all-important data that we need to help with our policies.
Thank you. Well, look, thank you everyone for joining us today. Thank you to a special thank you to our panelists and particularly to Mr. Sabanda for sharing some very difficult experiences with us. You left me at a loss for words through most of it. But I really appreciate that you shared them with us. To try and bring this all together, I think message 1, 2, and 3 are awareness, awareness, awareness of chronic kidney disease. I think, and then message 4 and 5 are probably that we need more data in this space. As a group, as the CKD Africa Collaborative and all of us at the George Institute, particularly the renal team, are very excited to work with you and try and help to address some of these very challenging issues that face us going forward. And I think probably the last is how to get data and policy and government change. And I think policy and government change, we've seen some examples of it. It's happened in India a few years ago. There has been bits and bobs of universal health coverage, particularly looking at dialysis coverage. There's we've done some work in Fiji along those same lines. So I think we can do it. But we'll probably all have to work together in order to do it together. Are there any other comments? I think both Dr. George's and Dr. Dawa's and my email address have been shared in the chat. Thank you, and we look forward to hearing from you.
Much.